Right, I think we're good to go. So welcome everybody. Thank you for joining in person for this preparing for the PSA series taster session. I've been asked by some of the final year leads to give a refresher session, just to kind of signpost you to the existing series that we've got running on the Mind the Bleep YouTube channel. So this will just be a little taster with also some kind of tips about the exam with some examples of questions from the series that you can find on the YouTube website. I've also got the chat function here, so if you've got any burning questions, do ask them. I am on my own, so I'll probably answer them at the end if that's okay. So my name is Sona, just to introduce myself. I'm the lead for the prescribing series and also for prescribing for Mind the Bleep. I used to be a pharmacist, then I switched over to medicine. So I'm currently in FY2 in A&E in London. All these are also recorded, by the way, all of our webinars, so this one will be as well, so you can refer back to it later. So just a quick one, we are sponsored by Wesleyan. If you scan the QR code here, you can find out a little bit more about them, but essentially they give advice and support on careers, finances, well-being, so it's quite a good thing, and it's free, so just check it out if you want. You can scan the QR code now or later. So this is just a shout out to the team that were involved with the series. So this isn't up to date at the moment. A lot of us have changed roles, but I just thought it's only fair to kind of make a shout out for these ones because these were the team that helped for the series that was in 2022. So we've got Salmia, Balamrit, Janice, Akash is obviously the founder of Mind the Bleep, and then there's me here as well. So, but this team has changed since. So just a quick one, whatever I'm going to discuss today, it's been sort of created for junior doctors and medical students, and by junior doctors who have a passion for teaching. It's completely voluntary, and the aim is to teach from experience, but just be cautious that, to the best of our knowledge, all the slides are correct. But, by all means, if there's any mistakes or anything like that, please do highlight them to us and we can address them. But we've tried our best to try and make sure everything is accurate, and you can check out the T's and C's here as well if you'd like. So, quick thing about the PSA structure. I've got this from the assessment blueprint. I hope you're all aware of this. You can find the PDF online, and it's I'm just going to close my camera. So there's a 2023 version available as well. I don't think there's much of a change. These slides are from the 2021 version that I used, but yeah, I think not much has changed. So essentially there's 8 sections to the exam, 60 items, 60 questions with a total of 120 minutes, and total of 200 marks. So you could kind of say there's 60 questions, 120 minutes, do 2 minutes per question, but I wouldn't recommend that. If you have a look at the breakdown, you can see that the majority of the marks are attributed to the prescribing section. So that's 80 marks. So I would highly recommend spending the majority of the time on this section. So I've just put a rough guide here, sort of based on how many marks per section. So I'd say 50 minutes on the first section, 20 minutes, and so on and so forth. You can have a look at this in your own time. And just at the bottom as well, there's a link to a article on Mind the Bleep's website that explains this a little bit more, and it's just got a bit more information on each of the sections. So as I say again, the majority of the marks are from the first section, so just make sure you spend enough time on there, so that you can get all the marks that you can get from there. Okay, and I just recommend doing the practice papers on the exam platform when you have access. I think you should have access about 2 weeks before. Right, so I'm going to go through just quickly each section, just sort of what you would expect. And these are screenshots from one of the papers that you can find online on the official platform. So the first section is prescribing. Essentially, they just want you to be safe and effective in your prescribing. What I'd recommend is to read the question stem really carefully, and then highlight or pick out some of the abnormal values. So for example, this person, 72-year-old, has come in, they've got a background of heart disease, they're short of breath, they've got edema. So it's kind of pointing to a heart failure picture. The respiratory rates are high, they're not saturating very well, even whilst they're on oxygen, so that they've got a lot of edema going on. And the question is pointing towards wanting to prescribe some furosemide. So just highlight some of the abnormal markers and then proceed to answering the question. And the majority of the questions will be sort of a STEM for this prescribing section, a STEM, a scenario, and then they'll ask you to prescribe an appropriate medication, or it could be IV fluids, anything that's relevant to the question. You get 5 marks for the drug choice and 5 marks for the sort of dose route frequency. Now, one thing I'd strongly recommend here is just to double, triple, quadruple check what you've selected, because on the drop down, say here you type furosemide, there's lots of different options. You've got injections, tablets, liquids, things like that. So, or combination tablets. So make sure you choose the right option. And sometimes if you scroll on your mouse and accidentally move to the next question and you've chosen the wrong option, that's 5 marks gone. So just be very, very careful with what you're choosing, essentially. One other thing to be aware of as well is potassium, for example, for safety, it already comes in pre-made bags of, for example, normal saline. You've got 20 millimoles and you've got 40 millimoles, but just be aware that in the drop down, it doesn't appear as 20 millimoles. So the 20 millimole one, if that's what you want to prescribe, is 0.15% solution. And the 40 millimoles is 0.3% solution. So that's something to be aware of, just in case, if you want to select a fluid or replace potassium, that's how you would find it. Okay. Yeah, please do let me know if there's any issues with the sound or anything, but I think we're okay. So next section is prescription review. So you essentially have to review a list of medicines, and normally sort of roughly 6 to 10, you'll get a list of 6 to 10 medicines, and there's 32 marks in total and 4 marks per question. And they essentially want you to identify inappropriate, unsafe, or ineffective prescriptions. That could be things to do with drugs, the inappropriate drugs, doses, or routes. Other things to look out for if the patient's got poor renal impairment, low blood pressure, electrolyte issues, drug interactions, things like that. A lot of it is BNF consultation, but also some assumed core knowledge. Make sure you kind of read the questions carefully. So question A wants you to select one thing, so you would just select one thing. And then question B actually wants you to select 3 things. So make sure you do select 3 things, because that's easy marks that you could lose out on if you're not reading the question properly, because you will be able to move on to the next question without answering all of the, ticking all the boxes. One thing I'd recommend is, even if you're not sure, you can see here, you can mark a question for review, but answer anyway. Answer something in the boxes, because you might actually, just in case you get flustered and you don't have time to go back in the exam, at least you put something, just make an educated guess, and at least you've put something as an answer. There's no negative marking, so you may as well put something. That would be a good bit of advice I could give you all. The next section is planning management, and here essentially they just want you to choose the most appropriate treatment option for a particular scenario. These are only 2 marks each, and there's only 8 questions in this section. The diagnosis or the differential diagnosis should be clear from the scenario, so don't worry about too much sort of thinking about, I don't know what's going on. It should be quite clear. And yeah, they want you to choose the most appropriate. All of them may be appropriate, but it's sort of the most appropriate for the question. So do read all of the answers. Don't just kind of jump to one answer. And also be mindful that, sometimes they might not even want drug treatment. Be aware of the role of non-drug therapy, so things like physios, OTs, things like that, for this particular section. The next one is providing information. So here is, again, it's the most important information to carers, and that's 12 marks in total, 2 marks each. Again, don't rush to answer the question, because if you have a look here, for example, this is talking about starting somebody on sertraline. And if you look at the options here, all of these could kind of apply to sertraline. You can increase the dose after some time. There may be nausea in the first week of starting. You can get withdrawal symptoms. And, it can take 6 to 8 weeks for it to start making an effect. But the most important thing here is about suicidal ideation, because that's sort of a serious, dangerous side effect. So again, read all the questions and then choose the most important thing, and don't rush to answer. I'm not going through all of the questions, because these will all be covered in the separate separate lectures in the prescribing series. I'm just doing a taster here, and then I have got a few questions as well for us to go through that I will go through with a poll. So the next section is calculation skills, and again, you've got 2 marks here, and it's just essentially appropriate drug doses, volumes, depending on what they ask in the question. You may need to use body surface area, and there's tables in the BNF for that. Drug dilutions, may need to give infusions or convert between units, things like that. So this can be quite time consuming, and all I would say is it's only 2 marks per question. So if you're getting really stuck, just move on. Because sometimes, you can get a bit flustered and spend too long on this and then miss out on other marks. It is only 2 marks, so yeah, just move on and then come back to it if you get really stuck with the question. The next section is adverse drug reactions. So here you've got 4 types of questions that they could ask in this section, and again, this is all in the blueprint, the PDF support for the PSA assessment, so you can get this online. So the first one, essentially, you get a drug, and it's like, what's the side effect of this drug? And you just choose one of the options. A type B question is, you may get a list of drugs, and then it could say which one is being potentially caused, which side effect is being caused by these list of drugs. Type C is to do with interactions, so drug-drug interactions, and I will shortly be talking about the best way to kind of look for drug-drug interactions in the BNF. And then a type D would be, for example, this has happened. For example, somebody perhaps has had an anaphylaxis to a reaction. How do we manage it? And then it'd be like, oh, give adrenaline or whatever the treatment option would be. So I'm not going to read through all this because it's quite lengthy, and you can have a look at it through this, in your own time. But essentially, there's 4 different types of things that they could ask you. So try and get on board with what you think the type is, and then it should help with answering the question. So next section is drug monitoring, and here you're monitoring the beneficial and harmful effects of medication, or you're seeing how successful something is, or how unsuccessful something is. So this one, again, you can use the BNF for some of the answers, but other times can be from clinical experience. So in this case, somebody is being started on furosemide, for example, and they're asking what's the most appropriate option to monitor the beneficial effects. So, furosemide has an effect on blood pressure. It will have an effect on ejection fraction, heart rate, and respiratory rate. But in this instance, they want weight because that's the most practical way for you to see, if it's working really, and you're looking for a 0.5 to 1 kg weight loss a day, depending on each individual patient. So that would be the option here. So read all of the options and make an educated guess, because these could all essentially be correct, but it wouldn't really be practical to be echoing everybody to look at their ejection fraction, for example. So in this case, it would be weight. Other things to be aware of and read up on is things like Digoxin, because that's quite a commonly prescribed drug in clinical practice. And when you're monitoring, so you'd want to take levels 6 hours after giving the dose. Other things, for example, for carbimazole, it can cause agranulocytosis, so you want to be monitoring full blood count. If you go in the drug monographs, in the BNF, and there will be a section down the side that will say monitoring if it needs monitoring. So have a look, and then in there it will tell you exactly what you need to monitor. So again, it's really important that you can navigate through the BNF online. The next section, we're nearly there, guys, is data interpretation. Here you'll be given some data, and you'll be interpreting the meaning of results, and if needed, making appropriate changes to prescriptions. You may need to withdraw medicines, you may need to reduce a dose, you may not need to do anything at all. So just read the question carefully and sort of answer accordingly. And everything or most things should be in the BNF. It's just knowing how and where to find them. And as I say, the whole first lecture on the series is dedicated to, the majority of it is dedicated to navigating the BNF. So I would recommend having a look at that. So at the end of the exam, you will get to a summary page. And I just want to highlight here, I don't know if you can see my arrow, but here you can see 0 for not answered. When you finish the exam, just check that you haven't got any numbers here because you want it to be 0. You don't want to miss out on really easy marks. So just make sure you've answered everything. The orange triangles at the top of question 2728 are the ones that have been marked for review. So you can easily see that and then click on those to redo the question if you want to change it. So just be familiar with the layout. And again, you should get access to the exam platform before the exam. So this is the exam platform. This is what you'll be faced with. Going from left to right, the A is abbreviations. If there's some terminology in the question that you're not sure about, you can click on the A and there'll be a list of abbreviations and their explanations. The book we will come on to, this is the BNF and BNFC. Calculator is self-explanatory, and then you've got these 3 lines which open up the assessment dashboard, so you can see kind of which questions you've marked for review, what question you're currently on. So that's the blue one. Okay. So the book, as I say, we'll come on to. Now, you can either access Medicines Complete or you can use the NICE BNF. I know NICE BNF you've got access to all round. I think Medicines Complete you'll get access to about 2 weeks before the exam. I haven't been sponsored by anybody at all, but I would recommend using Medicines Complete. That would be my choice. I just think it's easier to navigate, more efficient, and the interaction checker is really, really good on there. It's much easier to use than the one on NICE, on the NICE website. Have a look yourselves and see which one you like and just get really familiar with it. But personally, it's just been far better using Medicines Complete. And again, my first lecture sort of shows you how to navigate the interaction section and the BNF in general, and why I think the Medicines Complete is better. But by all means, use whichever one you're used to, but please do check them both out and see what you like. So the PSA blueprint, again, you can get from the assessment PDF. What I've done in the YouTube series, it's a set of 9 lectures, and I've essentially split them into these headings and tried to cover as much as I can of this blueprint. And myself and some of my colleagues have also delivered the sessions with me, sort of manning the chat. So we've tried to cover as much as we can. And today will just be a taster from some of the questions from the series. But have a look at this and obviously try and cover. Just make sure that you've covered all of the blueprint, or as much as you can. That's the best thing you can do, really. So let's have a look. This is the content covered in each of the sessions. If you guys, I'll just leave this for you to have a look at later. As I say, it's all on the YouTube channel, Mind the Bleep channel, and these are the people who gave the lectures. Okay. So this is the drug interactions. Just to highlight quickly, which is why I prefer the Medicines Complete. So in Medicines Complete, you go into interactions and then you type all the drugs that you want. So here, simvastatin, paracetamol, clarithromycin, and then it will come up with, it will do the check for you. So it will come up with each interaction and all of them that is possible between these 5 drugs. Unless anyone knows any other way, but from the NICE BNF, rather than the Medicines Complete, the NICE BNF, you have to go on the individual drug, and then you have to put you put one drug that you want to see whether it interacts with, or you have to scroll down the whole list and find one drug at a time, if that makes sense. And that's quite time consuming, and I haven't found another way to try and sort of write multiple drugs. So that's why I really like the Medicines Complete, because you write them all and then it just tells you all the interactions. So check that out, everybody. I would highly recommend. So just a quick thing, when you are using, the online version, make yourself really familiar with the guidance section of the BNF. Have a look at every section and look at what it contains, because then you can find things quickly in the exam. So for example, when you click on guidance, there's a whole section on prescribing and renal impairment. So that's got the Cockcroft and Gold equation, things to do in extremes of body weight, elderly. It's really useful. And there's also a really, really good section on prescribing in palliative care. So it tells you about pain management in palliative care, constipation, hiccups, interestingly. And I'll just check what's in the chat. So Rashida's just asked, the lectures have already been recorded. This is sort of just a taster, so you can find the whole series on there already. It's all recorded. So you can find the palliative care section talks about breakthrough pain, how to calculate breakthrough pain, dose conversion. So this is super helpful, and this is in the guidance, prescribing and palliative care section. So how to convert between codeine to diamorphine, dihydrocodeine, morphine. It's really helpful, guys. So have a look at this section and know where to find things, you know, to convert from morphine to a patch, or morphine to a fentanyl patch, buprenorphine patch. It's super, super helpful. Treatment summaries is another section. Have a look at. I couldn't stress this anymore. Even if if you're not sure what the question's asking for, but it's a urinary picture, just type in urinary. The treatment summaries will come up with lots of different sections to do with urinary stuff, urinary retention, urinary infection, things like that. You know, if there's a question about ears, type in ear. You know, if you're needing to prescribe antibacterials, just type in antibacterials. It just comes up with so many things. Have a look at the treatment summaries. Make sure you're familiar with everything, just so that you know how to find things quickly. Here are some of the other ones that I think are super helpful. So medical emergencies in the community as well. So that's all things about how to deal with hypoglycemia, hyperglycemia, drug overdoses, things like that. Just have a look at the section. As I say, the first lecture will cover a lot of this and sort of go into more detail, but obviously I don't have time to do all 9 in one, so I'm just going through this very quickly. One other thing I'd also advise, if you're control Fing particular words, make sure you're spelling them correctly. So, you know, have a look at the spelling. I think at the moment it's AE. If you miss out the A and you're trying to control F something, it may not come up. For example, if you're looking for side effects. So just make sure you're not making any spelling typos, because it may be a side effect and you've just sort of missed it. So I've just got some questions, guys, I thought might be helpful. So these are just taster ones from the just so you can get an idea of what the series is like. And these are just from the lectures I've given. There's lots of other lectures as well that I oversaw, but these are just some of the ones that I've given. So if you guys want to have a go at this first question, I'm just going to open the poll. And I'll just give just a few minutes, because I think there's about 8 in total, so I don't want to overrun too much, but just so you get a quick idea of what the series is like. So you've got a nurse looking after Jean. She's 78 years old, and she informed you that Jean is a bit more confused, trembling, slightly clammy, looks quite cachectic, and has not eaten her breakfast. She's got a background of type 1 diabetes, and she's on some various medicines for diabetes. The nurse does a finger prick capillary blood glucose, which is 2.0. And you're told in the question she's not able to converse and her level of consciousness is concerning. So what would you prescribe for the appropriate management of this condition? And again, guys, if you can get the BNF up and try and navigate it, try and use it, that will be super helpful. So this one you can actually find in the medical emergencies treatment summary. If anyone wants to have a go, just pop your answers, and then I'll give it 1 minute, and then I'll go through. And I can't see who's answered what, so take an educated guess if not, guys. Any more? We've had a few responses. Brilliant. There's a few more. Okay, so I'll for the purpose of time, I'll close the poll. But thanks for those of you that have answered. Right. So let me just close that poll. Okay, so well done for those of you that went with 100 ml glucose, 100 ml of 20% glucose. So if you have a look in the medical emergencies treatment summary, which is super, super helpful, you will find something about hypoglycemia. So if they're hypoglycemic and this patient's in hospital, so we can assume she has a cannula, in the question it'd be very clear to say, they do have a cannula or they've got IV access. Because we've got a concern about her level of consciousness, you would want to give something intravenously. So you either give 150 ml to 200 ml of the 10%, or you can give sort of double of the half of the 20%. So it really doesn't matter which one, but generally the aim is to give between 15 grams to 20 grams of glucose. So well done to those of you that went with 100 ml. 75 ml of the 10% wouldn't quite be enough, but it's better than nothing. But I don't think you'd get the marks. I've just put this slide on for reassurance, and guys, these are screenshots from the papers that you'll have access to online, so it's nothing new. So I just want to give some reassurance that you've got lots of different options that you can give and you'll still get the marks for. So you could give it over 2 minutes, 5 minutes, 10 minutes, 20 minutes, and in fact you can even give more. So here they're giving 150 ml of the 20%, which in the BNF it just says 100 is enough because that's 20 grams, but here they're giving 25 and they're still fine with it. So there's a lot of options that you can give, so it's not just kind of one correct answer. So I hope that gives a little bit of reassurance that what you wouldn't get marks for is if you gave it too slowly. So for example, over 4 hours, you can see up here what you wouldn't, the zero is what you wouldn't get marks for, because over 6 hours that's not going to be quick enough to correct the hypoglycemia. So I hope that gives you a little bit of reassurance in regards to kind of how you answer the questions. And here again you can see if you can give by mouth, and I saw some of you have given sort of 4 to 5 glucose tablets, things like that. You can do, but this patient in the question stem, which is why it's really important to read it, is they said that there's a worry about the patient's conscious level and their swallow, so we wouldn't be giving them any juice or any tablets. Essentially, that's why. Glucagon as well, you can give IM. I kind of put that in there as a red herring. You can give it, but this patient was quite cachectic, and in sort of states of starvation, things like that, the glucagon isn't going to work because you need to have a store of glycogen, which patients who are cachectic won't have. So that was a bit of a difficult question, but it's just also good knowledge to know that in these kind of states, so liver issues, starvation, adrenal insufficiency, these sort of things, you wouldn't want to be giving the glucagon. So all of these listed here. So I said liver issues, but I don't think that that's listed here. So yeah, just be cautious, and go with if they've got IV access, you can go with the IV. Just read the question stem quite carefully. Okay, so next is question number 2. So I'll just do the poll again for those of you that want to have a go. So we've got a 72-year-old chap called Bill. He's got known dementia, and he presents to A&E with his daughter. So he's not been himself. He's been mumbling some odd words which don't make much sense, and he can get sort of confused, but this is a bit out of character for him. He did have a UTI last month and he acted similarly. She's concerned it might be another one. And yeah, these are his results. So they did do a urine dip. There's nitrites are positive, leukocytes also positive. Blood ketones 4, BM is 8, and a VBG 7.29. He's got quite a low blood pressure as well. What do we think is causing his symptoms? So take all the information in, take a bit of time to sort of read the question. And what we've tried to do as well, guys, is make new questions. I think initially the first session used just screenshots, but the rest of the series have generally got new questions, which is just to add to the question bank. So I'll just give it another minute or two. Have a look at the results, so the ketones, the urine dip, the VBG. And again, the question is asking, it was sort of the most likely. So the emphasis is on the most likely. Oh, well done, guys. It's nice to see more of you answering. We're getting into... Okay, so I'll go ahead and close the poll. Well done for those of you that went for DK in a insulin-dependent diabetic patient. So I'll just quickly go through the reasons of why sort of the other ones aren't as likely to be the answer. So recurrence of UTI, it can cause confusion and change in mental state. However, we haven't been given any information to suggest that the patient is symptomatic for a UTI now. I know the urine dip is positive for leukocytes and nitrites, but in a 72-year-old, it generally is going to be. So we generally say skip the dip and send for a urine MCNS if you're concerned that someone's got a UTI. So that on its own, if the question said, oh, he's got some dysuria, some blood in the urine, things like that, then yeah. But the most likely, if you haven't looked at the rest of the question stem, it wouldn't be UTI. And the UTI is unlikely to cause raised blood ketones in the question of this context of this question. So DK in a non-insulin dependent. So that's not correct. So it is DK, but it's not in a non-insulin dependent diabetic person, because the Inhalet device, I'll quickly go back just to show you, because it's quite interesting. See here, the Inhalet device, that actually contains insulin, and it's for people who have sort of issues with, say, if maybe they've got arthritis and they aren't able to use the pens, they can use this Inhalet device. And also with vision as well, it's got the units a bit larger, and you can twist the dial to make the dose. So this person is diabetic. That's why that's not the answer. Constipation can also cause confusion, but I wouldn't say it's the most likely cause given the rest of the blood results. Again, yeah, pain can cause tachycardia, but not the most likely cause given the rest. So, and worsening dementia, it could be dementia, but it wouldn't be sort of as acute as the question has described. So the correct answer, well done to those of you. So it's DK in an insulin-dependent diabetes patient. So in DK, you essentially have a reduction in the net effective concentration of insulin and some elevation in counter-regulatory hormones. And this leads to extreme metabolic derangement. So for it to be DKA, you need capillary ketones of greater than 3 millimoles, or at least 2+ ketonuria, so ketones in the urine, a venous pH of 7.3, and or a bicarb less than 15, or a BM of higher than 11. Let me just have a look at the question. Oh, the reference ranges. They should give you, somebody's asking, they should give you the reference ranges. I mean, you don't quote me, but when you have a look at the questions on the PSA platform, the majority of the time they do, because also different labs use different reference ranges, so it'd be unfair for you to have to know the reference ranges, if you see what I mean. So I wouldn't be too concerned about that. So in this instance, because of the blood results that we saw, this patient is in DKA, and the mainstay of treatment is fluid resuscitation and reversal of metabolic disturbances. Just to point out for those eagle-eyed, the patient's blood glucose was actually 8 millimoles, so it's not over 11, and essentially you do need kind of all three, but the D can also stand for a diabetic patient. So generally their blood glucose will be over 11. However, you need to be cautious of these new medications called SGLT2 inhibitors, which can actually give you a euglycemic decay, where the BM could actually be normal, but the patient could still be in decay. And that's essentially because the way the drugs work, you pee out all the majority of the glucose, so you're in your bloodstream, actually it won't be that high. So just because their BM is normal, if they're diabetic and their ketones are up and their pH is down, you treat it as a DKA if they're on an SGLT2 inhibitor. It's really interesting. When I was working as a pharmacist, we had hardly anybody on those drugs, but now they're very common because they're also used in heart failure patients. So just be very, very cautious of that. Next question. So we have I think I have another poll for this. So this is just a taster of the calculation one. Again, these are all from the series. So there's a whole lecture just dedicated to calculations, but I just thought just to give you guys a taster. Let me just open the poll. And again, I will just give you just a few minutes, just so we don't overrun, because I'm conscious you've probably all got placement again tomorrow as well, or work. And all I'd say for the calculations question is read the question carefully. I know it sounds quite straightforward, but when you're flustered in the exam, you might oversee things or not kind of read the question as closely as you should. So just take some time. That's a brilliant spread of responses, because that's exactly why. Have a look at the question. One of those answers is correct. I don't know if you guys can see. So we've got either 2.4 or 4.8 ml, and it's all to do with the wording of the question. How are we doing? Let's see. Okay, I'll just give it one more minute. Okay, right. For the purpose of time, I will stop polling. Thanks, guys. So the majority of us went with 4.8, and some went with 2.4. So again, the question is asking for each day. So the 2.4 ml would be for one dose, but because it's twice daily, just make sure you're reading the question really closely. So it's 4 mg per kg. The patient is 9 kilograms. Yep. So that's 36 milligrams twice daily. So 72 a day. The solution is 75 and 5. So however I do 72 over 5, over 75 times 5, but you could do it this way around as well. It's 4.8 ml. 2.4 ml is one dose, but because it's twice daily and they're asking for the daily dose, it's 4.8 ml. So just read it closely, because those are kind of easy marks that you might lose out on. So next one, this is answered in the chat, if that's all right, guys. I will give you 3 minutes for this, because it might take a little bit longer. So this is to do with aminophylline, which is always quite difficult to sort of prescribe. And there's a following question after this as well. So we've got a patient who's suffering from severe acute asthma exacerbation, and they've had back-to-back nebulizers, they've had IV steroids, but it's still quite symptomatic. And the next step you could consider is IV aminophylline. But for IV aminophylline, you need to do a loading dose before you then do an infusion. So it's available as 25 mg per ml, and the patient is 60 kilograms. What volume is required for a 5 mg per kg loading dose? I will give us till 43, and then I'll go through the answer. If anyone wants to brave enough to pop it in the chat, go ahead. Thank you. Okay, amazing. Well done, guys. So we've had a few responses, and that's fantastic. That's 12 ml. Well done. So yeah, 60 kilograms times 5, 300 mgs. It's 25 mg per mil. 300 over 25 times 1 is 12 mil. Well done, guys. So the following question is, after the loading dose, he still had sort of poor management. So they need to do an intravenous infusion. And this is the rate. So it's 500 micrograms per kilogram per hour. And it comes in sort of, it's prescribed 500 mg in 500 ml sodium chloride. What volume needs to be administered each hour? So this one is sort of another step, another level up to the previous question. Anybody wants to have a go, you're very welcome, but it's also okay if you don't want to pop it in the chat. Just have a go at home. So I will go through this one, guys, because I used to struggle quite a bit with calculating this as well. So it's a 500 milligrams and 500 ml. So let's bring that down to 1 mg per 1 ml, because that's just much easier to deal with. And we're told that it's the infusion rate is 500 micrograms per kilogram per hour. So let's get the micrograms per hour. So we just do 500 times 60. So that's 30,000 micrograms per hour. Because our solution is 1 mg per mil, if we divide by 1,000, we can get it 30 mg per hour. And then essentially 1 mg per 1 mil, so it's 30. So 30 mg would be 30 ml. I think when you kind of go through it like this, it doesn't seem as bad. Just kind of just break it down into each section. As I say, this question also comes up in the series, so there'll be more of an explanation in that as well. But yeah, hopefully that makes sense. Just take each part in small parts and then put it all together. So I hope that makes sense. So question 6 is another poll. Here we go. So 64-year-old lady come into hospital with hospital for 5 days of treatment for severe CAP. She's not been eating very much, she's not got much appetite, and she's vomited quite a few times. She can see a yellow halo around lights, and she's more confused. She's got quite an extensive past medical, diabetes, hypertension, AF, and she's on a few medicines. Pay close attention. So any information they give you will be relevant. So have a look at the bloods, have a look at the electrolytes, highlight the things that are abnormal, and then choose the most appropriate decision in regards to the clinical presentation. So if they're giving you medication that the patient's on, that's very likely to be relevant. If they're giving you bloods, that's very likely to be relevant. And again, I've given you the ranges because if you look on when you have access to the exam platform, you'll see that you also have ranges there as well. And don't worry, guys, I think there's only 2 more questions left, so I won't keep you too long. Well done to those of you who've had a go. Okay, well done, guys. That's good. So let's go through this. So as I said, have a look at all the relevant parts to the question. So they're on. This question essentially is to do with digoxin. And some of the side effects of digoxin toxicity, you can actually start seeing sort of a yellow halo around lights. You get vomiting, you can get confusion. And the relevant things here is the patient's potassium is quite low. And one thing I was just going to say, sorry guys, let me so in the question, in some of the questions in the past, in the papers online, you'll get this image with a hourglass thing. Hopefully you can see the image on your screens, but this is it a little bit bigger. So if you get that, because you might get, for example, some like a prescription chart for fluids, and obviously that's going to be quite small. So click on it just so you can see it larger. So this is the ECG of the patient, and essentially the correct answer is D, to correct the hypoglycemia and take digoxin level. So digoxin toxicity, you get this really interesting reverse tick sign on the ECG. So it's kind of this bit here. And digoxin toxicity is more likely, and it's worsened when somebody is hypokalemic, and that's essentially because the channels that the digoxin and potassium both use similar channels to get into cells. So if potassium is low, then the cells will take in digoxin over the, because it kind of uses the same channels as the potassium, and because of that you then get the digoxin toxicity. And if you're using things like furosemide, for example, with digoxin, you need to monitor the electrolytes really closely, because furosemide can cause hypokalemia, so then that predisposes you to sort of increases the risk of digoxin toxicity. So you have to be really careful if someone's on digoxin to monitor use and ease, if in general, but also if they're on furosemide. Interestingly as well, if somebody's potassium is low, it's always useful to just add a magnesium onto bloods. You can call the lab and do it. You don't have to keep sending new samples, because generally if potassium is low, magnesium also tends to be low. And if you don't correct the magnesium, it's quite hard to correct the digoxin. So you just essentially correct them both at the same time. So well done to those of you who suggested to correct the hypokalemia and take digoxin level. And the digoxin level generally is taken 6 hours after the dose is given. Again, if you go onto the drug monograph on the online BNF and you scroll down to monitoring requirements, you can see everything that you need to know for the monitoring. So it will say this is when you should take the level, so at least 6 hours after a dose, and toxicity is increased by electrolyte disturbances. So it's really useful. The drug monographs are super useful. Just have a look at how to navigate them. If there's anything relevant, so for example, alendronic acid, there will be directions for administration. If you click on that, it will say about having to sit upright for 30 minutes after taking the dose, take it on an empty stomach, things like that. So there's a wealth of knowledge of information in the drug monograph. And then interestingly as well, in terms of, because it's quite a serious interaction, so if you're giving digoxin with amiodarone, dronadrone, things like that, then you need to reduce the dose by half. And also here, when switching between oral and injection, there is a dose reduction as well. So again, it's really interesting here. There's a lot of information in the monograph. So 2 more to go, guys. So another poll. Have a go if you like. We have got Mr. Adams, a 45-year-old who needs to be started on azathioprine because he's tried several other DMARDs and they have failed to work. Just a bit of information on his past medical. And the question essentially says, what is the most appropriate decision option with regards to commencing Mr. Adams on azathioprine? So again, if you know how to navigate the BNF and the sort of monograph, this shouldn't be too difficult to answer. Well done, guys. Any more? The lovely spread of answers. So what I've done is I've kind of gone to the drug monograph and I've just tweaked each of these of the 5 to make it slightly incorrect. So apart from one, so that just read everything closely, and then you should be fine. Right. So I will close that poll. Thanks everyone for answering. So the correct answer is to review TPMT levels prior to commencing treatment. So if you go onto the monograph and then there's a pre-treatment screening option. So again, on the left-hand side, you've got monitoring, administration directions, what to do in hepatic renal impairment. It's really, really helpful. Anything relevant. Some things might not have, if it's not relevant. So if a drug is hepatically cleared, then you may not have this renal impairment option, things like that. So anything relevant comes up here. So here it stresses the importance of checking the TPMT levels, because some people have a deficiency in it, and essentially that's the enzyme that breaks down the azathioprine. So if you give that to somebody that doesn't have the enzyme or has reduced levels, then they are at higher risk of toxicity from it. So generally you need to check the levels beforehand. So that's why that was the correct answer. The monitoring requirements, I know I did put some monitoring requirements, but if you kind of read the question, I think here it says use and ease, but it's meant to be FBC. And then the timings are slightly different. So it's blood count weekly, for the first 4 weeks, and then 8 weeks, and blah, blah, blah. So, and then thereafter you can reduce it to every 3 weeks if they're stable. So have a look at the requirements, read it closely, and then that should help with the answers. Okay. So well done, guys, for having a go. I think this is the last one. So if you want to have a go, we have a 38-year-old female who's come in for a GP checkup after feeling unwell for the past month. She's been on vacation for the last 2 months. She's feeling quite fatigued, and she's experienced episodes of overheating and intense palpitations over the past week. Her clothes have become more loosely fitted, despite no efforts to try and lose weight or diet. And she has poorly controlled AF. And this is her drug history. Again, everything that's mentioned is relevant, so just read everything closely and essentially choose the most appropriate decision option considering the information you've been provided above. And again, the whole point is that the majority of this should be in the BNF, so if you're able to navigate it and know where to look, then you should find these answers quite quickly. Okay, well done, guys. So we have a unanimous vote for arranging for TFTs. So well done. That is the correct answer. So again, if we go into the drug monograph, monitoring requirements, everything you need to know is here. So if you're starting someone on Amiodarone, then you'd want to be checking thyroid function before treatment, 6 monthly intervals, and for several months after stopping. So this is really important. And when you're working on the wards and you're doing medication histories, things like that, and it's always quite important to also ask about medications that's been recently stopped. Some patients don't think about, stuff that was stopped a few months ago, but it can be relevant, especially in the case of Amiodarone, because it's got quite a long half-life and it can persist for quite some time. So that's why I've put this questioning, because it's really really interesting. And then the other interesting thing is about this phototoxicity that you can get with Amiodarone. So you have to advise to use sort of high SPF, and even for several months after stopping the treatment. And really interestingly, I don't think you see it that often, but I actually saw it as a med student, and you get this grey man or blue man syndrome, but they kind of look grey, and this is a reaction to the sunlight, which is super interesting, and I think it can take months to years to clear. So I just thought that was an interesting fact about Amiodarone. That's it, guys. It was just meant to be a whistle-stop tour. just to cover some of the questions that have come up in the series. So the series is on YouTube. Mind the Bleep channel. It's called Prescribing Safety Assessment Series, and there's a set of 9 lectures on there, and essentially takes each section of the blueprint and tries to cover kind of as much as possible with our own questions. If I can possibly ask you to do the feedback, obviously we all kind of work off feedback, so I'd really appreciate feedback on this lecture.